Welcome to the North American Spine Society X, the Experts Program. I'm your host today, Vinicius Ferraz from São Paulo, Brazil. Today we'll dive into a topic that has become foundational to the modern surgical management of adult spine deformity, the role of spinopelvic fixation. To explore this critical technique from biomechanical principles to the latest technological advancements, we are honored to have you here with us, a true leader in the field, Dr. Tobias Mattei. Thank you for accepting our invitation, Dr. Tobias.
My pleasure, Vinicius.
It's my distinct pleasure to introduce Dr. Tobias Mattei. He's an associate professor at St. Louis University School of Medicine. Dr. Mattei plays a central role in shaping the scientific discourse of our own society, serving as the deputy editor of NASJ. Dr. Mattei, again, thank you for joining us today. Here we go. Spinopelvic fixation has evolved dramatically over the last few decades. From our perspective, what have been the most critical advancements that made today complex corrections possible?
So if you think about spinopelvic fixation and you go to the earlier techniques, several techniques described in the 80s and 90s, and then you have the iliac screw, which became the gold standard, probably for one or two generations before me. I honestly, in my training, I think I've used a few times, but I already grew up in the era of the sacroiliac iliac screw. But the bottom line is that in terms of spinopelvic fixation, and especially when we're discussing about deformity surgery, we need a robust construct sustaining our fixation. So we can discuss about biologics and hardware and techniques for insertion, but the concept of having a strong pelvic screw when we're dealing with deformity surgery, I think is something that is not debatable right now. I think it's widely accepted as the gold standard.
Okay, perfect. The lumbosacral junction is often described as the pivot point subject to immense cantilever forces in long fusion constructs. Could you elaborate on this concept and explain why traditional S1 pedicle screws are often biomechanically insufficient to serve a foundation for a multi-level deformity correction?
So the actual definition of cantilever is when you have a structure like a balcony that is hooked only to one end. So all the shear forces and the bending forces are at the bottom of the structure. That's not exactly what happens when we're doing a long spinal construct, because the screws at the top are holding. But it is true that most of the forces related to motion of the chest, and especially when you're talking about a T10 to pelvis. So you have the motions of the chest, then you have a very rigid construct, and then they have the motion of the SI joints and motion of the pelvis. So a lot of the stress are going to be at the lumbosacral junction. And if you think about S1 screws, you can put even a 9.5 screw sometimes, but it's not going to be longer than 35 or 40 millimeters. So, you're relying on a very short screw. And I think one of the things that sometimes is underestimated is the amount of motion at L5S1. I never cross L5S1 level without an interbody. And it's not an assurance that you're going to get a fusion, but if you don't use an interbody, you're assured to have a pseudoarthrosis at 5.1. So, again, if I'm doing an L3 to S1, I'm still okay stopping S1. Anything above L2, I think you have enough forces acting that you need a more robust construct anchor in the pelvis.
Okay, like short constructs, you are okay to stop, for example, to X1?
For sure. And if we're talking about AIS, for example, it's very reasonable sometimes to stop at L5. Adolescent deformity is very different, but in terms of degenerative deformity, yes, anything above L3, I would go to the pelvis.
Okay. The decision to stand to the pelvis is guided by specific radiographic parameters. In our practice, which spinopelvic measurements serve as the most critical indicator to a patient to achieve like a balanced outcome?
So if we think about patient-reported outcomes, the literature is very clear. The sagittal balance is one of the most important factors. We published together a very interesting paper on the GAP score and how that has changed the management in terms of more patient-specific parameters to achieve ideal correction. But the bottom line is that, SVA less than 5, PT less than 20, mismatch PI lumbar lordosis less than 10. That's standard, and a lot of the failures you will have is for either insufficient correction or failure to take those spinopelvic parameters into account. But one thing that, especially when you talk about pelvic fixation, that I think it's very crucial is sacral slope. We don't talk about sacral slope when we're discussing sagittal balance, but in my practice, if you have a patient with increased sacral slope, so those patients where the sacrum is very horizontal, the shear forces for L5S1 are a lot. So even, I had a few patients, especially with a grade 2 listhesis, L5S1, that I've gone to the pelvis or even one level above to L4 because, I mean, you have the horizontal sacrum, then you have a hyperlordosis to compensate that. And I think that's something that tells you that maybe the shear forces between L5S1 are not going to be, it's not going to be enough for just a S1 pedicle to hold that.
Yeah, you mentioned before the Euler screws. And today, a central debate in technique is a choice between the traditional iliac screws and, for example, the S2 Euler screws. In our experience, what's the compelling surgical and clinical advantage of the S2 AI screws?
I mean, I think the main thing is that I see in my practice, I mean, being a low-profile screw is a major thing. We've all seen, especially for patients that are relatively thin, if you use a traditional iliac screw, patient may end up feeling the screw and they're upset with that. You can even palpate through the skin. The second thing is that aligns very well with your rod construct. So if you're doing an Euler screw, you definitely need a side-to-side connector, and that's one more point of failure. So those are the two advantages, and I would say older surgeons, they are more familiar with iliac screws, and it seems that the placement, even freehand, may be a little bit easier, but especially nowadays that most of us, we use navigation, some sort of image guidance, but even without that, the safety of the S2 or even S1 or S3 Euler iliac screw is something that I think that's what the vast majority of deformity surgeons are using nowadays. Yeah,
and despite our best techniques, the aggregate rate of spinopelvic fixation failure is over 20%. For example, the pseudarthrosis and rod fracture being the most common ones. In our practice, what is our go-to strategies to create the most powerful lumbosacral environment to make these corrections possible?
I mean, important things like evaluating having bone mineral density before the surgery, knowing what you're dealing with, if necessary, using cement augmented screws. But in terms of the rate of pseudarthrosis for pelvic fixation, I don't think it has much to do with the surgical technique. I mean, a lot of the screws that I had in my practice that sometimes after 2 or 3 years you start seeing some lucency, they're well placed. And some of them, they are even getting the cortex close to the sciatic notch, which is supposed to be a very strong region. But one of the things, and it just, even though it's an 8.5 by 90 millimeter screws, which is probably one of the longest screws you can get into the human body, so you think that that would never fail, but it just illustrates how much forces are applied on those screws. So one of the things that a lot of groups have been using, I think the data is still kind of getting there in terms of the efficacy, but I think it makes sense, and that I've been doing routinely in my practice, is to fuse the SI joints when crossing with a sacroiliac screw. So the way I personally do, I use the sacroiliac screws, and through the same opening, I do a screw that you can either cross from S1, it's a hollow screw, so you can pack with bone. You can even cross from S1 to the iliac, or what I like most, I go right at the joint, and I can even do 2 of those. The one I use is the Rialto screws, but you can even do, so we ended up with 4 of those. And the idea is that the screw completely disrupts the 2 cortex of the SI joint. You have bone in between. So I think it's almost the same concept of doing an inner body fusion. You're doing an inner body SI joint fusion, something like that. You're really, it doesn't make sense to me to cross the joint with a screw and still have a joint that is moving or causing pain. So if you cross the joint, I think you have to fuse.
And this, do you think this technique you mentioned that you do SI joint fusion with these specific screws could lower the rate of the SI joint pain?
That's one of the things. I mean, the literature on both SI joint pain as well as in the rate of failure, it's still only based on retrospective studies, so there's no prospective study comparing doing or not doing SI joint fusion. But those are the two things that you want to address, is to try to reduce the rate of pseudoarthrosis, and because you're fusing the SI joint, reduce the SI joint pain, which is not uncommon in deformity. And you just have to take into account that you always have to worry about the next level. So the next level, if you fuse the SI joint, is the hip joint. So if a patient already has hip degeneration, that may be something that you want to take into account when deciding to do an SI joint fusion. But again, you're already crossing the joint with a sacroiliac iliac screw.
Perfect. And in case of lumbosacral pseudoarthrosis fixation failure, could you touch on the role of salvage techniques like S1, Euler screws, S2, or even S3 Euler screws?
Correct. So we published initially, I think I was in my fellowship, and there was nothing in the literature about combining S1 with S2 AI. So we published the first technical note on that. And then in my practice, I had cases that the sacral anatomy was distorted, so we had to use S3. And I didn't see anything in the literature. I saw a morphometric study with CT scan evaluating the feasibility. So we published the first technical note on S3 sacroiliac iliac screw. But there's not much secret. I mean, it differs in terms of the angle. The S3 is almost perpendicular or even pointing up a little bit. But those are the situations that I still use. Sometimes you go check the anatomy. If the sacrum or the ilium is too disrupted because of the lucencies, you may even have to go back to traditional iliac screws. I had one case a few weeks ago that's what we ended up doing, removing the S2 AI screws and going traditional iliac screws with side-to-side connectors.
Perfectly. Finally, Dr. Mattei, for the many spine surgeons in our audience who are managing these challenging deformity cases, what's the single most critical piece of advice and pearls of wisdom you would offer when they are planning to and executing, of course, a surgery that requires this kind of spinopelvic fixation?
So one of the things is to be familiar with the technique, of course, and not be afraid of going to the pelvis. Like I said, I mean, any construct that you're expecting to have a significant amount of forces, even considering the patient BMI as a proxy for how much stress would be on the construct. The other thing is, of course, using image guidance. I would not perform a sacroiliac screw without navigation, not because I don't know how to do those, but you can get the best anatomy. You can get the best possible screws for that specific patient, the longest screws. So have in mind about combining and having this arsenal of S1 or S2 and S3. And then, of course, I keep a long-term follow-up. Some people stop following with CT scans after 6 months or a year. You may not see the pseudoarthrosis in the iliac portion of those screws even beyond 2 years. So you have to follow those patients, because otherwise they're going to have some residual pain and you're not sure if it's a failure of your surgery or indication, and lo and behold, they have a problem that can be resolved by revising the bottom of the instrumentation.
Dr. Mattei, thank you very much for sharing your time and expertise with us today. On behalf of the North American Spine Society, we are grateful to your expertise, and to our audience, thank you for joining us on the Ask the Experts.
Thank you very much, Vinicius. My pleasure.